a 58-year-old female presents with persistent, localized knee pain that is worse at night. I am showing you an AP radiograph, along with coronal T1, coronal stir, and axial post-contrast T1 weighted magnetic resonance images of the distal femur. Please describe the findings.
The radiograph demonstrates a mineralized intramedullary lesion in the distal femoral metadiaphysis with endostele scalloping of the medial cortex. The magnetic resonance images confirm a 5.9 centimeter lobulated mass with T2 hyperintensity, endostele scalloping, cortical thinning, and peripheral lobular enhancement.
What is your primary diagnostic concern?
The combination of clinical pain, the large size of the lesion, and prominent endostele scalloping are highly concerning for a low-grade intramedullary chondrosarcoma.
What is the classic radiographic calcification pattern of a chondroid matrix, and what does it represent?
It is the rings and arcs calcification pattern. This represents calcification around the lobules of mature hyaline cartilage within the tumor matrix.
What is the primary radiographic and histological mimic of this lesion, and why is the differentiation challenging?
A benign enchondroma is the primary mimic. Differentiating them is challenging because they show identical chondroid matrix, and histologically both consist of low-grade chondrocytes within hyaline cartilage.
What specific imaging and clinical features on radiographs and magnetic resonance imaging help distinguish a low-grade chondrosarcoma from a benign enchondroma?
Key features include persistent pain, lesion size greater than 5 centimeters, endostele scalloping exceeding 2/3 of the cortical thickness, cortical destruction, and bone scan uptake greater than the iliac crest.
Why is a medullary bone infarction in the differential diagnosis, and how does it appear on magnetic resonance imaging?
A bone infarct displays similar calcifications. However, on magnetic resonance imaging, it exhibits a characteristic serpentine low-signal border with a double-line sign, and lacks the lobulated T2 hyperintense chondroid morphology of a cartilage tumor.
What is the characteristic post-contrast enhancement pattern of chondroid neoplasms?
They demonstrate peripheral and septal enhancement, which corresponds to the vascular fibrous septa surrounding the non-vascular cartilaginous lobules.
Finally, what are your clinical management recommendations?
I recommend referral to an orthopedic oncology surgeon. Management typically involves biopsy followed by complete surgical curettage or wide local resection, with close long-term radiographic follow-up to monitor for local recurrence.